So we're going to look a little bit at what opioid addiction looks like and how it is currently treated, or at least the options for how it can be treated. So there's been a large rise of opioid overdose deaths, and they're often going to have to do with the introduction of new versions of the opioid into the market. So in the late 90s, there are a lot of drug companies that started very aggressively marketing their drugs to doctors as miracle painkillers. And so there was a large rise in the prescription of opioids. With that rise, there was also a rise in prescriptions. There was also a rise in prescription overdose death. As prescription users started transitioning, as we sort of started to fully understand the long-term consequences of those increases in prescription opioids, a lot of people lost access to their prescription. So they transitioned over to heroin, which you do not need a prescription to get, and it's also significantly cheaper than buying pills. Additionally, several years later, other more synthetic opioids became more widely used, such as fentanyl. But they can either be prescribed or they can be illicitly manufactured. The jump here that we see in overdoses is significantly sharper than what we see with heroin or prescription because these synthetic opioids are so much more potent than either heroin or opioid addiction or opioids. So the opiate effects that we discussed earlier are going to very clearly align with the withdrawal effects. So when you're on opioids, you see a lowered body temp. When you stop taking them, you start seeing an elevated body temp. This can also, you will start feeling chills. You will not necessarily feel warm, you'll feel cold, but your body temp is being elevated. You see an increased blood pressure instead of decreased blood pressure. You will start seeing piloerection or goosebumps. The emergence of goosebumps when you stop using opioids is where the term cold turkey comes from. Your skin looks like cold turkey. You see diarrhea instead of constipation. Instead of seeing nodding, which is an effect where people who are high on opioids will start to drift off to sleep, and as their heads start to go down, they wake back up and they sort of pop their head back up. You can also see this in undergraduates or professors who are listening to boring lectures or talks or came to the lecture or talk deeply sleep deprived. You'll see their head drop and then you'll see it bounce back up and drop and bounce back up. When this is being caused by an opioid, that's referred to as nodding. The parallel withdrawal effect is insomnia. You can also experience pain. A lot of people talk about how their skin is on fire when they stop taking the opioids. It's because there's a bounce back in the analgesia. So your body has been suppressing pain signals previously. So now stimuli that wouldn't normally be painful are now experienced as pain because those pathways are so hypersensitive. This is actually thought to be mediated through changes in glial and the spinal cord, but we're not going to get too much into that. So usually opiates called euphoria and calm. When you stop taking them, you can get depression and anxiety. So if you know the opioid effects, you can remember the opioid withdrawal effects because they are basically in parallel and opposite. Okay. So in considering different opioid addiction treatments, you have several different options. You can have a detoxification. You can have it cold turkey, meaning you just stop taking it. It's going to be ultra rapid. This is induced by naloxone. So if you have somebody who is experiencing opioid overdose and you treat them with naloxone, also known as Narcan, usually by giving it up the nose, they will immediately go into withdrawal. So many people, if you work as an EMT or you work in an ER, you will most likely experience at one point saving somebody who's having an opioid overdrawal. You'll be saving them with Narcan, and they will wake up angry because you have taken them from a place where they were high into immediate withdrawal, which is very negative. You can also have a gradual detoxification, which is usually going to involve some sort of replacement therapy, which we will talk about. Naloxone is an overdose treatment. It is a competitive antagonist. It is very effective. You sometimes need you might need multiple doses in order to outcompete the amount of opioid that's in the system. So if, for example, you have a high concentration of fentanyl, you will need more doses of naloxone to overcome that than a slight overdose of heroin. Replacement therapies mostly aim at preventing withdrawal effects and stopping that sort of negative affect feedback loop. There's also antagonist therapies that basically, by taking them, you prevent the reinforcing properties of opioids. So if somebody decides to use again, it won't feel as good, so hopefully they won't do it. So the main opioid replacement therapy that is used is a methadone. It is a mu opioid agonist, but it is a partial agonist. So similar to heroin and morphine, it is going to interact with the mu opioid receptor. It has similar effects, but it has a much longer half-life and does not cause euphoria. So as you can see, the intensity of the drug effect is significantly less. You don't get this sudden and high peak that makes heroin so reinforcing. You get a peak that takes much longer to come up and goes down. It's being administered orally. Usually it's given as a syrup. You usually have to go to a clinic to be given it. So the intensity of withdrawal, so if you started using methadone to get off of heroin, you will experience withdrawal, but the withdrawal is significantly less intense. So that intensity of withdrawal correlates with the intensity of the drug effect. It will prevent the worst opioid withdrawal symptoms, which makes people able to function. It must be taken orally. It has to be administered by a doctor. This means that if you want to go through methadone treatment, you have to physically go to a clinic every single day. This is a huge undertaking, especially for somebody who's experiencing job insecurity or does not have reliable access to transport. Their whole life basically becomes about getting to methadone clinic and then getting back again safely. And it's very hard to sort of build the other things in your life that would help you stay clean while being preoccupied with getting that methadone and getting back home. The risk of overdose is greatest in the first 4 weeks of treatment. So when you first start using methadone, if you combine it with heroin, you're much more likely to experience an overdose, right? While it's not a full agonist, it is still a partial agonist. So when you combine it with heroin, the effects are going to be additive, and you might experience an overdose at a dose of heroin that you wouldn't have before. When you stop using the methadone and you start experiencing that withdrawal we talked about over here, you're also more likely to overdose. At this point, you haven't used heroin in a long time, you used methadone, and most likely your tolerance is significantly lower. The compensatory mechanisms have shifted for this less intense effect of methadone. So the dose of heroin that was previously safe for you now becomes an overdose level. So people don't know what level to titrate to themselves anymore because they haven't compensated for that loss of tolerance. And so you can see overdose 4 weeks after leaving treatment. So that's methadone. Another one that's that's very common is Suboxone or buprenorphine. I used to ride the bus in Pittsburgh, and there used to be a lot of posters that advertising for buprenorphine studies that people could participate in. It is a partial agonist of the mu opioid receptor. It requires partial detoxification. So unlike methadone, you need to stop taking heroin for a while and go partially experience detox before you can start taking Suboxone. So it is an initial investment in an unpleasant experience to try and get a better outcome long lasting. So it is given by a sublingual prescription by a specially licensed doctor. You have to get specialty training in order to describe buprenorphine, and there is a large undersupply of people who are trained in this way, and we are not properly incentivizing people to go get this training, especially in rural areas that have been hard hit by the opioid epidemic. People might have to travel hundreds of miles before they can find a doctor, and it might be very difficult to get in with that doctor because there's a limit for how many patients each doctor can give prescriptions to. So you might say, so at first, when you first get trained, you're allowed to oversee 30 patients who are on buprenorphine. If that goes well for a specific period of time, then you can start you can bump that number up to 100 patients. But if there are thousands of people within a 100-mile radius of you and you're the only doctor, it's going to be really hard to treat that level of need. Buprenorphine is usually prescribed with naloxone to prevent the misuse, so that if you take buprenorphine or if you try and take more buprenorphine than you're supposed to as the dosage, it will not get you high because the naloxone is going to interfere with that effect. So that's going to contribute to the ceiling effect, that larger doses do not cause a larger effect at that point. That's similar to that sigmoidal curve that we see. Hitting that sigmoidal curve is the top of it, the top plateau is going to happen more quickly with buprenorphine. With buprenorphine therapy, we see about 52% relapse, which is quite high, but it's significantly better than a lot of other therapies that we've seen. Something else that is not available in the US is prescription heroin. Dimorphine hydrochloride specifically, which is pharmaceutical heroin. This is legal in Switzerland, the Netherlands, UK, Canada, and Denmark. You have to come to a hospital. It is administered under medical supervision. The goal here is to prevent overdose and people doing desperate acts, committing crime in order to get access to heroin. Additionally, you're constantly bringing this population into interactions with the public health system. So if they feel that they do want treatment or they're having a severe medical problem, it can be caught and treated quickly. They also develop relationships of trust with people within that system, so they feel that they have places they can go and get treated fairly. So that's a major benefit here. It is fairly successful, but it is used mostly for patients who have not been helped by other treatments. So if you've tried methadone and you've tried buprenorphine and you have relapses each time, it's considered sort of a last resort. Oftentimes, the places where people have to take the heroin is surrounded by mirrors, so they have to watch themselves do this act, so that they sort of have to face the choice that they're making all the time, right? However, the downside of prescription heroin is that you may need to be on it indefinitely. Also, you will need to go to the hospital every time you want to take heroin. So you will most likely spend all of your time going to and from that hospital or hanging around that hospital, which can make it difficult to find a place that is willing to have the clinic, because people don't want addicts hanging around all the time. An antagonist therapy like naltrexone is a competitive antagonist. It's going to require full detoxification. Most people basically quit here, so it doesn't have a high success rate. Naltrexone can be given once a month as a maintenance dose. It is much harder to get high or overdose. So while you're on naltrexone, if you took heroin, it is not going to get you high. It's also much less likely that you are going to overdose. If you start taking it though, and then you stop, your tolerance has been reduced, similar to what we saw with methadone, and the risk of overdose is significantly higher. You have a lot of problems with compliance. People do not like this and will not stick on it unless they're required to. It is most successful when the user is highly motivated with strong social support and career prospects. So if this is somebody who has family support and their family is saying, if you can get off of it, you can be welcome back. We will make sure you get a job. We will make sure you're supported. If they have something to go back to, it's much more successful. If somebody is coming out of prison, for example, does not have career prospects, does not have family support, and you try and put them through naltrexone, it's not going to be effective, right? Because they don't feel like there's anything worth fighting for. So that is the overall on opiates. If there's something else you want to hear about, just shoot me an email, and I can post an additional video.